Well, here it is Thursday, again, 4:30 p.m. Now it is Pacific Standard Time for those of you who are on the East Coast, or maybe those of you who are across the Atlantic Ocean, at least over there, or if you're across the Pacific Ocean, welcome, because we are going to talk about hormones today. So every Thursday evening, I can't get myself right here. Every Thursday evening, we are going to be joining here 4:30 p.m. to bring our team here at Brio to you to discuss a wide spectrum of things related to integrative medicine, particularly related to cancer. And today we're going to talk about hormones. So I brought one of my esteemed colleagues, because at Brio we have a unique environment where we bring together really a team. You know, it reminds me, Miranda, Dr. LaBant, forgive me, I played college football. So for me, it's about bringing together the team because it's the team that's going to win the game. And Dr. LaBant, who has had the pleasure of doing some of our webinars, is one of our esteemed colleagues, and she is very well equipped. She is excellent in the arena of integrative oncology. And why don't you tell them a little bit about your experience before we dive into hormones?
Absolutely. Well, I'm really excited to be here with you this evening and to be diving into this subject. My background as a naturopathic physician, I actually found my way into integrative oncology. But when I first started in practice, I was, as a naturopathic physician, you're really trained to look at the person as a whole. Right. We treat the gut, we treat hormones, which we're going to dive into today, but we see the body as not just these pieces and parts, how all of it works together. And one of the things we might talk about today is the estrobolome, right, which the beneficial bacteria of our gut and how they play a role in hormones. And so, you know, in just my practice, as it's evolved, it's really more focused now on fully integrative cancer care, right? We practice together. You see that. But in that piece, and when we're taking care of patients dealing with a cancer diagnosis, we have to look into all of the other, I call it spokes of the wheel, right? Where we have to look at all of the aspects that could be contributing to someone's health and their outcomes, essentially. And hormones are, they're so intertwined in this process, right?
And you know, Aristotle had a great quote, "The whole is greater than the sum of the parts," which ties into exactly what you said, and in fact, when you look at the team at Brio, right, beyond you and I, there's Dr. Rumbi, Dr. Ruda, Dr. Kim, and all of our amazing nurses, LPNs, front staff. And yeah, I'm not going to mention them all by name because I'll leave one out and I will never hear it again. But we have the best staff in the world. We do. And I don't say that lightly. And because I've had a lot of chances to work with a lot of great teams, nurses, medical team, staff, and we have the best. And they bring together that quote quite well, that the whole is greater than the sum of the parts. And it really ties well into hormones because, you know, I've often said that most of what's out there as it relates to hormones, Dr. LaBant, it's more of a marketing-based medicine than actually evidence-based medicine. And I'll give you an example. The way it's presented is that hormones are simply a estrogen-fueled hot flash or a testosterone-fueled erection. Now, obviously crude, but that's the way it's presented, is it not?
It's true.
Yeah. So how do we counter that?
Well, hormones are, I mean, there's so many different kinds, right? It's not just estrogen. It's not just testosterone. We have hormones that regulate our sleep-wake cycles, our stress.
Right.
We have hormones that regulate us being hungry, full, right? All of these really play into a role. But I don't know how to, if we're going to counter that, what I think is really interesting is when we think about hormones, we think about depletion or areas of imbalance, right? But when we step back and look at all of this, actually hormone replacement, birth control pills, we use these things to deal with symptoms that are actually really showing us ultimately a hormone imbalance. What's really interesting though is that hormone replacement therapy, and I know that I'm opening a box right now, but hormone replacement therapy, birth control pills.
You're opening a can of worms.
I'm opening a big can of worms, and I'm happy to do it. Are grade 1 carcinogens in themselves. And I'm really excited to kind of dive into that. And I know you and I are going to eventually do a series on this.
Yeah, and that's a good point, because there's 6 hormones here, and there's many more that we could talk about, but we're going to dive deep into them, and we're going to talk about them as it relates to cancer. And I think that's the important concept. And I think the way we counter it, Dr. LaBant, is we counter it with evidence. Instead of marketing-based medicine, we counter it with evidence-based medicine. There was a really interesting slogan marketing campaign that a company in the Southeast was doing many years ago, back when I was just in the wellness movement. And it was Know Your Number. And I found that really interesting, because they really, in a microcosm, really, summarize what I'm talking about. Because they're simply saying, hey, as a guy, what's your number? That defines who you are as a man. And I thought, how silly, but everybody bought into it. Everybody got it. What's my number? And they just got it completely wrong. But because it's not evidence-based. When you focus on the evidence and follow the evidence basis in this, you have to understand, when you look at hormones, there are many different factors that go into this. It's not just what are your hormone levels, but it's what's the proper hormone evaluation. Is it blood? Is it urine? Is it saliva? Of course, the knowledge of your hormone levels. What's the balance, Dr. LaBant, as you correctly mentioned? The balance that nobody thinks about is the enzymes, the metabolites, which I want to dive into. Hormone receptors, cofactors, the hormone response elements, the outside influences, and then just simply the physiologic hormonal environment, as you mentioned, the microbiome contribution to that. And then there's issues such as genomic versus non-genomic signaling, and then crosstalk. So all of this encompasses what you said beautifully, which is it's kind of looking at things as a whole, not just individual parts. So is this something that you were taught in your training and your education, or is it something that, because I mean, you're a smart cookie, you know that. That sounded really weird, but you are an excellent physician, and I'm proud to work alongside with you at Brio. But is this something that you just took an interest in, or I mean, how did you really get into your understanding of hormones?
Yeah, well, with the training in naturopathic medical school, we have all the basic sciences, but then when we learn about the different systems, right? So our class in endocrinology not just reviews all of the physiology, but how to treat that from a root cause basis. So we don't just learn how to do patchwork with estrogen or patchwork with testosterone. We learn those pathways and the cascade of hormones, right? And I'm sure you also learned that as well in conventional medical school.
No, I just learned you prescribe birth control pills and you prescribe hormones when they reach 45 years of age or older. Well, I mean, really.
That's actually fascinating to know that. But when we think about how hormones are produced, it goes all the way back to cholesterol, right? And over the years, we've had like low-fat diets. Cholesterol's bad. It's so bad. And don't get me wrong, there are parts of cholesterol and fat metabolism that are unhealthy. But we actually need cholesterol as the main building block as a precursor to all of our hormones.
Oh, we need both cholesterol and cortisol. So
yeah, we do need that
good.
too.
Yeah, we need both.
But we learn these pathways in depth. And then as I got into practice, what's really interesting is in my early career, I was doing a lot of hormone replacement. And as my practice developed and I started having more of a focus on oncology, I started taking a deeper dive into hormones and how they play a role in cancer. And it was a few years ago, I think in 2018, and I don't have the study to reference right now, but there was a study that came out looking at hormone replacement. And that's really what piqued my interest, because this study had shown women, most specifically, that were put on biased, so estradiol, estriol, were at a significantly increased risk for developing any type of hormonally driven cancer. When the study further kind of extrapolated, and with the addition of progesterone as well, significantly increased the risk for developing hormonally driven cancers also. And so with that, I started looking into other testing that could be done, hormone metabolite testing, to really understand how people break down these hormones with the liver metabolism, and is looking deeper into their genomics and their genetics, screening patients more properly before just saying, oh, you know what, your testosterone's low. I know you have a low libido, your energy's not the best, you're not able to build muscle in the gym, without thinking about it, right? I did that before, I'll admit it. And once I took a deep dive into the research and really understood what was happening, understood how to screen patients properly. I'm not saying all hormone replacement is bad. I do think that patients need to be properly assessed before diving into that. But when we're talking about cancer, it's a whole nother level.
And you know, I think you and I have kind of made a very similar journey, because when I got into, and I'm a gynecologist by training, and I was not kidding you, our Friday afternoon lecture series, so it would be like from noon to 5, if it was about hormone, it was the hormone replacement company or it was the birth control pill company. So they sponsored our lunch and all of our lectures. If there was a guest lecturer, they were sponsored by them. And so it was through that prism that we were brought into this this concept of what hormones were. And it was really an adulterated view. But as I got out into the medical practice world, I started to discover that what I taught was not really working for everybody. So that's how I got into hormones. But as I've migrated through the clinical practice years, because I'm right at about 20 years now, everything as it related to hormones, the question of cancer came up. So what is the implication of my hormone balance or imbalance and cancer? Okay, I'm taking hormones. What's my implication there? I had breast cancer or prostate cancer. What's my risk now? And so for me, everything became very evident that cancer was a part of the hormone discussion. But as I've migrated through my clinical practice, I've moved away from the idea of aggressively using hormone replacement in patients because of the environment within our body. I think if the population as a whole was healthy, if the environment, the gut microbiome, you talked about estrobiome, I actually hadn't heard of that term. And I pride myself on words, so kudos to you.
Yeah, we can talk about that.
Yeah, that's right. Well, I'm familiar with the concept, just not the term. But how we change, we evolve as we experience, and that experience gets applied to the science. And it's interesting, you as a naturopath, me as a medical doctor, we took very similar journeys that have really brought us here to Brio, and the way we approach hormones, the way we approach cancer treatment is very similar.
Yeah.
I don't believe in coincidences.
No, it's a beautiful thing.
Yeah, it is. And as you can tell, I truly enjoy working with her. She's such a joy. So let's really blow their minds, because what we're going to do, we're going to go into some detail in upcoming webinars where we're going to dive deep into estrogen metabolites, progesterone metabolites, testosterone metabolites, thyroid metabolites. We're going to knock your socks off with that one. Cortisol, and then melatonin. So we're going to go into each one of those in a different aspect, but really to empower you as patient. But let me just give you a little bit of a taste here, how complex these hormones can be. Because again, even doctors look at hormones as, you know, an estrogen-fueled hot flash. But what if I told you that there is a male hormone, 3-alpha-androstenedione, which is a direct metabolite of dihydrotestosterone, the most potent androgen? It binds to the estrogen receptor and can signal via estrogen. What if estrogen can bind to dysfunctional androgen receptors? These are male hormone receptors in prostate cancer. What if insulin growth factor 1 receptor actually binds and activates estrogen receptor alpha? So in cancer, when insulin and insulin growth factor are binding to the receptor, they could actually stimulate estrogen receptor. You don't have to have estrogen to just stimulate. And then looking at thyroid, this again, thyroid in cancer is really unique. Here, thyroid, particularly T4, in a study from 2011, showed it will stimulate ER-positive lung cancer. So the concept of hormones are not just this simple process. I actually had a patient one time say, brevity is the soul of wit. And I was like, that's a good point. I don't think we're trying to be witty. We're just trying to be scientifically accurate. So let's dive into what is hormone metabolism? Because when people think of metabolism, Dr. LaBant, I imagine the imagery of weight comes into that. Overweight, underweight. But give an idea of what is hormone metabolism. What does that look like when we look at a test panel that looks at that?
Well, it's an incredibly important concept to dive into, because we think about hormones as these kind of, they're chemical messengers, right? They go around and they tell the body what to do, what to control, what to regulate, but where do they go, right? What happens to them? And we have this concept that, we produce estrogen and then it just goes away, right? But all of that metabolism is really occurring in the liver, a lot of it. And a lot of it's happening in the gut as well. And when we look at hormone metabolite testing, it's allowing us to have a broader picture, a broader understanding of what's really happening. But that metabolism, and you're diving into some really interesting deep concepts about how hormones kind of are
rabbit holes. Yeah,
a lot of rabbit holes.
Yeah.
But I guess I'm just touching on the overall concept of hormone metabolite testing, right? Because when they
all tie together, though.
Yeah,
they really do.
But we think about testing for hormones in the serum.
Yeah,
right.
But
I also think that's it's FDA approved, it's inexpensive, it's common,
yeah,
right?
Clinically, it doesn't provide a lot of
doesn't provide a lot of context, right? Because we have receptors or hormones that should be bound and unbound. We don't really want to see high levels of hormones in the blood.
Correct.
When we talk about metabolism, the breakdown of these hormones, there's so much that's involved there with our own mechanics, our own machinery, our metabolics, right, of the liver and these CYP enzymes and how the body's breaking it down. And when we do either saliva or urine, most specifically metabolite testing, we can look deeper into those pathways, how the body is processing it. Is it utilizing it in a appropriate way or in an inappropriate way that could potentially be driving these more oncogenic processes, right? And we think about that most specifically with estrogen metabolism.
And what we're going to do is in the coming series that we do and produce here, and it's not going to be every week, but we will be bringing that to you, is show how complex these issues are. Because when people look at progesterone, for example, they think, okay, low progesterone is associated with increased risk of breast cancer, and clearly there's research that suggests that. But then they think, well, then de facto, let me give progesterone and that will counter that risk. Well, there's actually a team that's done research on that says, well, it depends. There are progesterone metabolites that actually increase breast cancer risk. And again, it's not about marketing, but it's about what the evidence actually shows. So I like to dive into the word. So metabolism, it's the total of all chemical reactions which occur within the body. So here we're talking about hormones. Now, there was a 2018 study that said metabolomics examines the changes in metabolites or metabolic changes over time. So metabolomics is that new area of research within what's called multiomics. It's looking at all the metabolites. Now, how many are we talking about here? Well, a lot of great places you can go to evaluate what are metabolites. They are essentially the products of biochemical reactions. So let me just give you some numbers to blow your mind here. There's estimated 37 billion cells in the human body with an estimated 1 billion chemical reactions occurring every second in every cell, yielding a grand total of 37 billion trillion chemical reactions in the human body every second. Remember, every chemical reaction is a metabolic marker of metabolism. So we could be inserting hormones, 37 billion trillion, maybe hormone metabolic reactions.
Right.
Kind of opens the context of what we're talking about here.
Constant change and
Ever.
flux.
So we will often look at different hormone testing, right? Because we don't ignore blood testing. We look at thyroid in blood tests. But what about doing blood tests, urine, and saliva together? Are they telling us the same thing, or are they giving us different windows into a physiologic environment?
It's showing us different aspects, right? Like, for example, cortisol.
Right.
Cortisol in the blood is so, I think, ambiguous. So it can give you a quick, spot of where that cortisol is in that moment, but there's so many factors that can truly influence it. When we look at cortisol metabolism in the urine, for example, we can actually look at free cortisol. We can look at metabolized, meaning what's getting broken down in the liver. And it gives us a better understanding of what's happening with the hypothalamal pituitary axis, the HPA axis, which we could talk about this all day long, but cortisol in itself is so involved in tumorigenesis and immune suppression, inflammation. I can't wait to dive into that particular concept with you, but it does give us this understanding of different areas. So if we want to look at something just really quick, a spot, understanding maybe someone's medication, is it working, or is there adaptogen herbals doing what they need to do? You can do a quick spot blood test. But if you really want to get a whole picture, you have to utilize all different areas. Saliva testing for cortisol, you can look at the cortisol awakening response, CAR. Again, we can go deep into this, but the cortisol awakening response, we don't think about cortisol stimulating our immune system in the morning. Yes, it increases glucocorticoids, but what those glucocorticoids do is they stimulate thymocytes, which help to get rid of unhealthy failed cells of T cell regulation, right?
That's why you look at breast cancer, a high cortisol, that's immunosuppressive state, and that obviously is how cancer can evade and spread. But then low flat cortisol, research has shown, is very, very concerning for breast cancer recurrence in those that have remission. So we're not just talking about, when we talk about hormones, hormone metabolites, we're not just talking about giving hormones, right? We're talking about understanding the hormonal environment within the confines of the body to actually influence, to affect change, to actually change the environment so that it's no longer hospitable to cancer. I mean, it is a therapy, but we don't necessarily come in with hormones, right? All the time. We do sometimes. But let's give them a little bit of a taste, and then we'll get to some questions. So I encourage you to drop some questions, and we'll discuss those. But let's take 6 prominent hormones, and just a little quick pearl. I'll take one, you take the other. Well, actually, you start off first. But just give a quick pearl about estrogen and cancer. That's something that maybe the average person, and doctor included, may not know about.
Yeah, estrogen is very prominent, right? Alone, estrogen is proliferative, right? We think about it during menstrual cycles and hot flashes, but with cancer, and not just hormonally driven cancers, estrogen actually has the ability to cause proliferation in all different types of cancers because these cells can have hormone receptors on them. You alluded to that earlier.
Oh, really kind of all cells.
Well, right, but you alluded to that earlier with lung cancer having estrogen receptors on it. We don't typically think about that. We actually have a patient currently at the clinic, I know this is a side note, but we have a patient currently at the clinic with non-small cell lung cancer. That patient was taking testosterone prior to the diagnosis, and we ran some genomic testing, right, and we saw that it had androgen receptors on it. Right. Those can translate, or, androgens can aromatize into estrogen. But I think that for me, the take home with estrogen itself is that it's so proliferative. Right. And it's not just associated with hormonally driven cancers like breast, ovarian, prostate. It can be associated and cause proliferation in all different types of cancer.
And that's a perfect point. And you can't extrapolate it across all different tissue types either. So when you look at androgen receptors, it's estimated that somewhere between 70 and 90% of all breast cancers express androgen receptors. Yep. And the suggestion is maybe that's protective, maybe not. Right. And then there's other cancer types where androgen receptor expression, i.e. lung cancer, is a negative prognostic, I can't even say it, a negative prognosis signal. Yeah. Looking at progesterone, I referenced the group. Dr. Wiebe was the lead author on many of these articles, looking at progesterone metabolism, really breaking it down into two pathways, the 5-alpha-pregnines and 4-alpha-pregnines. And it's the 5-alpha-pregnines that were associated with increased breast cancer. So those rushing to take progesterone when they have breast cancer, or I know there's people that advocate for progesterone in prostate cancer, the question is, what's the body going to do with these hormones? And here's the analogy that I'll give. If I leave a box of matches on my counter at the house and I take my beautiful wife out on a date, who I will in just here a moment, and I have a 5-year-old child, which we don't, but we have had 4 at that age, there's a concern that we might burn the house down. But if I leave my 25-year-old child at the house, who is living with us right now, I shouldn't have that concern. It's the environment that dictates a different response. That's what's happening within the confines of a body, but within the confines of cancer. So what about androgens, the male hormones, a unique pearl there?
Well, androgen receptors, they're, they also, different than estrogen, but they promote the growth of not just normal cells, but also cancer cells, right? They are, in a sense, these kind of very, very metabolically active hormones. And so we can see androgen receptors. I think you mentioned this earlier, not just, we think about it driving prostate cancer, right? But we can see it in triple negative breast cancers. Yes. We can see it elevated in different colorectal cancers, right? And so, androgens are not just testosterone. It's also DHEA, which are also these precursors to testosterone, which can also further metabolize down into estrogen. Another reason looking at the metabolism of these hormones in a much deeper way.
And in fact, for our ladies out there in the audience, all your estrogens come from the male hormones. In the ovulatory years, that is the reproductive years, it's just happening within the thecal cells of the ovaries. There's a little flashback. Whoa. But that process occurs right within the ovaries. Then when you transition through menopause, over 80% of estrogen for women comes from fat, the abdominal fat. So when you look at men that are, have a big belly, that's where you typically see those kind of, those man breasts, and they come from the aromatization. That is perfect evidence, physical evidence of the amazing capacity of what hormone metabolism run afoul can do.
Right. Well, we think about hormone susceptibility in just women, but men can also go through what is called andropause, right? And we see this depletion or this, we think about low testosterone, but you're speaking about a very real process that happens, especially in men that maybe are overweight, right? Their fat cells can actually take that testosterone and metabolize it over to estrogen.
Some of my most hormonal patients have been men. I mean, and I don't say that out of jest. It's been real. We just express it differently. We don't have hot flashes, night sweats, and mood swings. We just go buy red cars. It's just we express it differently. Cortisol, it's really interesting, high cortisol, because there's high and low. It's found in advanced cancer typically. So the more advanced stages, the higher the cortisol typically. It'll shift the immune system from a Th1 to Th2 balance, which favors carcinogenesis and immune evasion. It'll actually promote mutagenesis and inhibit DNA repair, which is a very pro-carcinogenic process. It promotes growth. It inhibits apoptosis, programmed cell death we've talked a lot about over on the podcast. And here was an interesting thing that I thought was really interesting. You'll find tamoxifen. Okay? 6 weeks of tamoxifen elevated the plasma cortisol concentration by 26%.
I mean, tamoxifen is also a grade 1 carcinogen.
When I was walking, I never forget, great attending. We were walking through the oncology floor, and he said, so patients on tamoxifen, diagnosed with breast cancer, just had surgery. I said, okay. And I said, so tamoxifen, yeah. I said, that's a selective estrogen receptor modulator. He said, right. And he said, what's the risk with that? I said, uterine bleeding. And so I asked him, I said, and we were right there on the rotation, I said, so how well does it work? He said, well, 50% of the time it doesn't work. It's like, well, that's interesting. And I knew the literature on the bleeding risk and what came from that. And so 50% of the times tamoxifen doesn't work, and 50% of the time it causes uterine cancer.
Right.
So I was like, wow. Now there is something most people don't, think about. They think when they're being prescribed a drug that it's going to be working 90 to 100% of the time. But here, 50% of the time it doesn't work, and 50% of the time, maybe whether it works or not, it's going to lead to endometrial adenocarcinoma.
Right. Not ideal.
Not at all. What about thyroid?
Thyroid. We think about thyroid as our like metabolic regulator in itself, right? Whether we're hot or cold, or whether we have anxiety or bowel movements or not. But thyroid, interestingly, when you look deep into the literature, I think about mostly thyroid stimulating hormone. And from a conventional perspective, when patients are being assessed for thyroid function, we just look at TSH and say, right. Oh, okay, your TSH looks great. I don't think you have any issues to worry about. No problem. What you and I know is that we have to look deeper under that iceberg, right? And one thing, a pearl, I guess, if you will, about thyroid and thyroid stimulating hormone is that a lot of different types of cancer like to use TSH, right? Thyroid stimulating hormone. All of our cells equally have thyroid hormone receptors on them. Yeah. And that is no different for cancer cells. A lot of the research was actually initially focusing on melanoma, and TSH being a growth factor or proliferating factor for melanoma. And I think you and I both understand that it's not just melanoma and thyroid cancer, but we also see it being a proliferative factor if it's not controlled in many different cancer types.
Yeah, thyroid. And when we talk about thyroid, that's going to be one you will not want to miss. It is, I mean, it's amazing how it's often mismanaged, misunderstood, and how thyroid therapy can simply be promoting cancer because of how the metabolites affect cancer genomically and non-genomically. Different topic for a different day. And I'll close up and then we'll get to some questions in just a second. On melatonin, I think if you've been in a closet the last 20 years, you may have not heard about the impacts of melatonin on cancer, but it is enormous. It is tremendous. Melatonin is marketed as a sleep hormone, and it comes from the pineal gland. But here we're talking about the effects of inflammation on disrupting melatonin as a metabolite. So instead of 5-hydroxytryptophan to tryptophan to serotonin to acetylserotonin to melatonin, and then beyond, inflammation disrupts that and converts that. We were talking about this just the other month, what's called the disordered tryptophan metabolism. You find this in excitotoxic diseases such as Alzheimer's and dementia, Parkinson's. And then you also see this in cancer, where this inflammatory process disrupts the metabolism of this hormone. And then as a result, you have lower melatonin that impacts your immune system negatively. But here, this suppresses your immune system through this disrupted disordered tryptophan metabolism. And so what's interesting is when you give melatonin to these patients, you actually disrupt that disordered tryptophan metabolism. And so we'll dive into that as well and talk about the evidence of melatonin as a hormone in breast cancer and each one of these individually, but then how metabolism of these hormones impacts cancer, how we can evaluate that, and how we can affect change. That's the power. That's the power of this knowledge, right? It's affecting change. Yeah. It's affecting change. So let me, we got our brand director here. And first of all, shout out to Pascal and Eden Visuals, man. That's right. Peace up. And shout out to our brand director, Aaron. So, all right. So my husband has esophageal cancer. Is there a way to know if it is hormone driven? He is on Fulfox and Opdivo. I have him taking high-dose melatonin and liposomal vitamin C along with some other supplements. What testing do we need to ask for? So how would you start off with that question? I
don't know if I heard the whole question.
Oh, sorry.
I was trying to see if I had the question.
Yeah, so husband has esophageal adenocarcinoma. She wants to know first, is it a hormonally driven cancer? How would we evaluate that?
I think a tissue assay would be the most appropriate way. I don't know if we're allowed to say companies or anything like that, but a tissue assay or a tissue sample we could send that out for evaluation. And it's not just looking at the genomics, but it also looks at the receptor status, and that's one of the ways that we evaluate that at our clinic.
Yeah, so if your husband has had a biopsy or had a resection of that tumor, they hold on to that pathology, that tissue, for usually 5 to 7 years. And so you can actually, your physician can actually go back and restain that, because they don't routinely do estrogen, progesterone, androgen receptor staining of those tissues. So you'll have to get your physician to request that tissue would then be sent to the lab would then stain it, and then your doctor would have access to that. So I'm going to break this up. She said that he's on Fulfax and Opdivo and taking high-dose melatonin and liposomal vitamin C along with some other supplements. So let's talk about that. So melatonin, I mean, we never sat down and talked about what your thoughts are on melatonin and cancer. But I know we've talked about disordered tryptophan metabolism, but talk a little bit about melatonin.
Melatonin, I mean, we think about it as this hormone that helps us sleep, right? Every time you and I prescribe melatonin to patients, they're like, well, I'm sleeping fine. It's like, no. Melatonin is anti-inflammatory. It has very potent anti-cancer properties. It helps our body drain the lymphatic system, right? So the lymphatics of the head and neck, that's so appropriate. It helps with restoring bone metabolism, right? Especially if we see bone mets. So melatonin is not just this hormone that we use for sleep. It really helps to put out fires. It's an antioxidant. It helps to reduce inflammation. And then, we also have the anti-cancer support involved with it. So I'm a huge fan of melatonin. I've been using it for a long time in high doses as well.
Yeah, it's a aromatase inhibitor too. Yeah. So melatonin is a very useful hormone to use in cancer. Liposomal vitamin C, going to be recording a podcast tomorrow. I think that's important because when people look at vitamin C, talking about how do you treat cancer. Now, vitamin C is clearly not a hormone, but taking vitamin C by mouth, whether it's liposomal or non, you cannot achieve blood levels that are therapeutic, pro-oxidative. Actually, I'm going to be doing a podcast tomorrow highlighting that. So check that to drop soon on the Practicing with Dr. Nathan Goodyear podcast. Shameless plug, I know. So we talked a little bit about the testing there. So here's one. With the rise of personalized medicine, how are hormone profiles being used to tailor cancer treatments for individuals? Wow, that's a great question. So I'll start off this way. What we've been dealing with the last 100 years is basically the one-size-fits-all approach to medicine. That is intuitively, so, if a patient that is 6'6" sitting next to a patient that's 5'2", and they have the same histological type of cancer, let's say it's breast cancer, because we've seen our fair share of men with breast cancer, and yet they're treated the exact same way. But intuitively, if you look at the hormones, you're going to see that, they're unique, they're individual. It's personalized. It's the right treatment for the right patient at the right time. So do hormones give us that ability to personalize our therapy?
Absolutely. Yeah. Absolutely, it does. I mean, I read hormone metabolite testing on a daily basis, and there are very few reports that I get back that are similar. And so when
normal.
But when we talk about individualizing care, your body's different than mine, than Aaron's, and so there's always has to be individualization. But when you look at this kind of testing, you can actually look deeper into some of the methylation pathways, the genomics, and you can make changes there dietarily, nutritionally speaking, but also with supplementation. You can actually redirect these pathways with the right support. And so it does help to tailor treatment. Absolutely.
Yeah, just to give you some insights to the complexity, people go, well, what is my diet? How do these things all interrelate? Well, if you're eating a really poor, typical American diet, and you're creating a lot of inflammation system in the gut, and you get, as a result of that breakdown of the gut lining, you get what's called a leaky gut. You get a disrupted microbiome in the gut. And what will happen is some of these bacteria, particularly the gram-negative type, you'll actually get leakage of some toxins that they have into the systemic circulation. And this will upregulate systemic inflammation, and that in turn can upregulate the conversion of the male hormones into estrogens. So your diet could actually be affecting your hormones. And again, when you look at men, as you mentioned, andropause, women, menopause, you're seeing a reflection physically in that manifestation. And so when you look in cancer beyond the age of 50, well, historically, let me rephrase that, beyond the age of 50 is really where you've seen a lot of these hormonally driven cancers take off. But what we're now seeing today is that cancer is becoming more and more a disease of those under the age of 50. So the cancer that we knew, which is one we'd rather never know, but the cancer that we knew is not the cancer that we know now or in the future. It's changing, and hormones are part of that.
I mean, breast and prostate cancer is now one in 7 of us, right?
I think if you really look at the literature, Dr. LaBant, it's 1 in 1. If I mean, that's according to the prospective urban rural epidemiology study, as I talk about so often. In high-income countries, cancer is the number 1 cause of mortality. So give time. If you live long enough, you're going to get cancer, unfortunately. And that's why prevention is so key. Whenever I have a chance to talk to doctors, what I tell them is, how many cancer doctors do we have in the audience? And, a few will raise their hands. But what I tell them is, every one of you are cancer doctors, because every one of your patients, given a long enough lifespan, will encounter cancer. So you need to work on prevention. So from a patient undergoing hormonal therapy, I'm currently undergoing hormone therapy. What should I expect in terms of side effects, and how will you monitor the effectiveness of the treatment? Good question. I'm
assuming they mean hormone suppressive therapy?
Well, I mean, you could be talking about, aromatase inhibitors. Could be talking about, GnRH agonists, basically shutting things down centrally. So not really, they didn't really elaborate on there, but let's talk about those two. There are hormone therapies that shut the whole system down, right? And then there are hormonal therapies that kind of interfere. So just differentiate those two just a little bit.
Yeah. So, I mean, when it comes to
now this is from a conventional standpoint.
Yeah, hormone suppressive therapy, we have aromatase inhibitors, right, which kind of shut down that process of testosterone being converted to estrogen. And those are a lot more effective at really shutting down that hormonal process. And then we have what we were talking about earlier, tamoxifen or SERMs, selective estrogen receptor modulators, where it's only shutting down maybe parts of the hormone metabolism. And then when it comes to prostate cancer, we have androgen deprivation therapy, which shuts that down, but also can shunt things over still to estrogen. And so we see that happening. What I can say about all of those, regardless of what a patient is on, is some patients tolerate them just fine, and others really struggle. And that's where that individualization comes in. And if patients are on any of those hormone blocking agents, there's a lot that can be done to support patients through that process, right? From a more natural perspective, dietary wise and also supplement wise.
And I think it's important to understand is the science is never settled. So with time comes new innovation and new discovery. There's actually a newer therapy out there. Goodness gracious. It's called bipolar androgen therapy, which is basically, it's called BAT, where everybody looks at prostate cancer. We'll use that as an example, and they think that basically all testosterone causes prostate cancer. If that was the case, every man at the age of 25, 26, which is peak testosterone production, would have prostate cancer. flip that to ladies. If estrogen caused breast cancer, every woman at 25, 26 would have breast cancer. And it's just not the case. What happens is in cancer is cancer starts to manipulate its environment for its survival, for its benefit, and the body's detriment. So in prostate cancer, for example, it's misusing the male hormone. And so what BAT therapy is it's a relatively new treatment, but it's coming in with actually very short, about 30-day big boosts of testosterone dosing to actually decrease the growth of the cancer cells and resensitize the cancer to treatment. So very interesting how new discovery is allowing cancer to be targeted with testosterone, which most people will look at prostate cancer and think, well, testosterone is causing it. Why would I want to do a 30-day treatment of testosterone therapy? Well, if it expose sensitivity to your prostate cancer cells to that central hormonal therapy, wow, that's using hormones evidence-based and using it in a hormone metabolite viewpoint. But we use melatonin, right? Mm-hmm. So what about women or men that have high estrogen metabolites in a very pro-carcinogenic way? We wouldn't necessarily use hormones there, but we would want to interfere with that metabolism process, right? Mm-hmm. How would we do that?
Yeah. Well, I think the first place to start would be dietarily. There's a lot of different components from cruciferous vegetables, diindolylmethane, indole-3-carbinol, sulforaphane, which help the body and the liver to actually break down all of those unhealthy estrogen metabolites. When we're speaking about prostate cancer, I think that's what we're speaking about.
It could be breast for that matter.
Right, but I mean, in the context of prostate cancer, right. We think about androgens being that proliferative piece, but when the prostate's inflamed, no matter if it's from prostate cancer, prostatitis, BPH, there's a layer in the prostate that actually starts to produce estrogen. And so we have to take a look at estrogen metabolites regardless of the cause there. But I think dietarily and using those compounds that I was just speaking of is one really successful way to address these different hormone metabolite pathways. And I know we haven't really gone into, the 408 for hydroxyesterone pathways and all of that, but we can manipulate and shift those with these compounds. And dietarily speaking, with those cruciferous vegetables is a really profound way to do that.
Yeah. So when your mother told you to eat your broccoli, she was talking about not your broccoli and the health benefits. She was talking about your hormone metabolites. Yeah. Just leave it to mom because she knows it all. She knows it all. It's really interesting. She's touching on the environment around cancer. It's not a solid ball of cells. There's actually some beautiful articles being written about the complexity of the tumor microenvironment. Mm-hmm. It's a combination of different environments: a metabolic microenvironment, immune microenvironment, a hypoxic microenvironment, a microbiome, acidic microenvironment, innervation, there's nerves there, and then mechanical microenvironment like fibroblasts. But I would say they didn't reference this. This was a 2022 article, but there's a hormone microenvironment within the tumor microenvironment, and that's going to be different than the rest of the body. Just because somebody has cancer doesn't mean their whole body is cancer yet. Now, obviously, as things advance, that can occur, but even within the confines of a normal functioning human body, if cancer exists, there is normal function within that body, but there's function of not normal. Mm-hmm. There's not normal function within cancer. So these two coexist, these two environments coexist, and it's really interesting. Treatment reflects this. Mm-hmm. Vitamin C, pro-oxidative in cancer, not in healthy cells. Methylene blue, it has different effects in the cancer versus healthy cells. Photodynamic therapy, curcumin. So this principle exists, but hormones are also a reflection of that as well. We had a couple questions, Dr. LaBant, about fertility. I think really good. One's concerned about her hormone treatments, how it might affect her future fertility. And then a question from a person by the name of Abby, love the name. One of my deepest fears is how hormone treatment may take away my dreams of having a family. Is there a way to safeguard my fertility to hold on to hope for life beyond cancer. How would you reflect those as a woman?
Well, I do think that, as a woman, that subject touches deep, right? Because if that's a desire or that's someone's calling that into their life and having that taken away by a diagnosis, whether the treatment has been with chemotherapy, whether it's been with radiation, both of those can greatly suppress fertility. But hormone suppressive therapy is a big one. And I think that there are times when patients can come off of those pharmaceuticals, right? And there is a lot that can be done to actually restore. But I don't know the age of this person. I don't know the context of the case. I've seen many women that have come off of hormone suppressive therapy and still be able to re-stimulate their fertility, if you will. Acupuncture is incredible for that. There's a wonderful herb called chasteberry vitex, incredible at re-stimulating cycles. And so there is hope in that, and there's a lot that can be done for patients that are in that situation and kind of facing that. But you have to weigh all of that, right? Again, I don't know the whole situation. As far as, kind of where her status is with her particular diagnosis.
I thought there was a couple good questions there, because I think it would, as a woman, it would hit home to something that I as a man can't reflect upon. But I know, past being a gynecologist, that what we would do in that instance is we would counsel them and say, look, typically these hormonal therapies they have a lifespan, meaning typically you're not on them the rest of your life. And if you're young, you're healthy, there would be a phase where if you opted to use these, because you can opt to not use these, that is the conventional. What we do in the integrative mode is we bring a natural, holistic, and integrative approach to this. And what we want is efficacy, but we want high quality and function. So in those instances where a woman opted for the conventional route and suppression, then when they came off of those hormonal suppressive therapies, then given time, you could actually see a recovery there. If there was a concern about that not happening, then you obviously could counsel them about egg harvesting and getting that process ahead of the cart, if you will. So there's great options available, but in many cases in young women that are healthy, they can recover. So for men in prostate cancer, it usually is a different situation. But I think this is going to become a bigger and bigger issue as we see the demographics of cancer shifting. I think we're going to have to talk about this a lot more. And one of the things that I don't think medicine is ready for, is how patients are more empowered. They want to be cured, quote unquote, though that's not a clinically validated endpoint. They want to have no evidence of disease for decades and decades to come. But they are more and more not willing to sacrifice quality of life for that. So conventional medicine is going to have to kind of come to grips with this concept of, this authoritarian doctor-patient relationship is no more. It is now doctor with patient. The patient is the star quarterback. The doctor is the coach working to help the patient achieve the best outcome. And I think medicine is going to have to learn how to navigate those waters. Right now, it's not doing a good job. I think we at Brio-Medical do a great job. And it's like today, Thursday, every day for an hour, we sit there and we talk about patients. We talk through complexities of their issues that they're struggling with, labs, etc. I mean, even Dr. Kim today brought up the, BRCA germline mutations in a couple of the male patients. I think one was prostate cancer, one was breast cancer. How we were using some of our specialty testing there. So, we're at a dawning of a new generation and a new paradigm in medicine, and hormones is definitely right in the center of it. Absolutely. Right in the center of it. So, right now we're fast approaching. I'm going to have to hold on to this question because this is a good question, but it's a question where now we have 4.5 minutes to answer. So I'll go ahead and read it, and we'll have to answer it when I think we talk about stress, and so that'll be upcoming, Dr. Burke. But the question is this: in the context of psychoneuroendocrinology, how does a stress-induced dysregulation of the hypothalamic pituitary adrenal axis and subsequent alterations in hormone levels potentially impact cancer progression and patients' response to treatment? It's a very articulate question, Dr. Burke. Great question. Moreover, what strategies or interventions are recommended to mitigate these effects and support overall hormonal and emotional health in cancer patients? It's a very thoughtful question. It's a very deep question. And what I would say is I think there's a lot of ways that you can take this. And I'll take it this way, is that when you look at stress is a physiological response that we can measure. Many people think of cortisol as the only stress hormone. There's norepinephrine, there's epinephrine. These are all involved in the stress response. And I've experienced that as having had a pheochromocytoma. Let me tell you what, when your norepinephrine and epinephrine's up, whether your cortisol is up or not, you feel like you're about to jump out of your skin. So this hormonal signaling, this response, has a very negative impact on your immune system. So not focusing on necessarily the central impact, in my short answer here, Dr. Burke, I would say when you look at an elevated stress response, it has a very immunosuppressive state. And when I look at cancer, this is a very concerning issue, because what we know about the tumor microenvironment is that it's an environment that we have to extrapolate what is going on because we have no ability to intimately test it. We have to look at blood work and extrapolate that urine, extrapolate that saliva, extrapolate that into that environment of the tumor microenvironment. But we do know through the research, animal studies, in vitro, in vivo, etc., that what's happening is in the stress response, it is suppressing the immune system within that tumor microenvironment, which is critical in immune evasion, a very critical rate-limiting step in how cancer will evade the immune system and spread from a localized disease to a systemic disease. And the important point here is that that does then affect the primary cause of morbidity and mortality. That is metastasis. So in a very brief here at the end, great question. We will address that in the future, I promise you, because it is a brilliant question. Its impact on the immune system, because what I often tell patients is the best answer to cancer is never get it. It's prevention. Beyond that, the best answer to cancer is your immune system. So you've talked a lot about this, and we'll wrap up after you answer this. But what's the relationship between stress and a diagnosis of cancer? Is there a connection between chronic stress, acute stress, and the actual diagnosis and development of cancer?
Wow. That is a big
Okay, you got 27 seconds.
You're right. So
I'm sorry.
Here we go. So, chronic stress, acute stress, it doesn't matter what it is, right? It's immune suppressive, right? If we just kind of fast forward through the cycle of chronic stress and cortisol, right? You've talked already about the tumor microenvironment. It releases these pro-inflammatory cytokines. It causes neuroinflammation. I know Dr. Burke was asking about psychoneuroimmunology, right? We see these neuroinflammatory pathways also upregulated. But at the end of
feeds up to the brain.
But at the end of the day, stress is stress. Stress, it could be a car accident. It could be a death in the family. It could be foods that you're eating that are causing immune responses that are causing stress on a cellular level. All of this stress, no matter where it's coming from, it's unhealthy, right? It causes immune suppression at the end of the day, and it causes dysfunction in the regulation of all of these hormones, all of these different processes, all of these different metabolic pathways. And so it's a conversation I have with almost every single one of our patients. I went pretty in depth with one of our patients today about the emotional stress response, right? Because we're living modern day life. We're exposed to stressors all of the time. Chemicals, conversations, business meetings, it doesn't matter what it is. We have to find ways to process that stress and to deal with that stress, whatever that might be for someone. And there are so many outlets: prayer, meditation, yoga, going for a run. I mean, the list goes on, right? But processing old trauma, suppressed anger, suppressed grief, all of these things play into stress, and they have a huge impact on us cellularly, and ultimately, in my opinion, to the development of disease, right? And cancer is a part of that.
Yeah. So, stress in the short term can obviously be helpful. It can boost the immune system, but we're talking about, significant stressors. We're talking about, chronic stressors. And a good friend of mine, Dr. Eldred Taylor. So if you're listening out there, buddy, it's good to talk to you or talk at you. Reach out to me. He actually brought me into this integrated world many years ago. Actually, a fellow gynecologist as well, lives in the Atlanta area. And he talked about the difference between stress. He said, stress is something every organism deals with. Mm-hmm. He said, look out there, look at the zebras. He said, they have stress every day. Their stress, though, is very acute. It's very short. If that lion or that cheetah, they see that lion or cheetah, they run. That stress response kicks in. Two things happen. They get away, stress goes away, or they don't, and stress goes away because of their dinner. So, that is the animal kingdom. My wife hates those kind of movies that show all that. And when we look at stress, and I think the question that Dr. Burke's getting at deeper here is the impact systemically of the stress that we can't get away from. And you brilliantly talked about how it's not just, I had a stressful day at work. It could be what you're eating, your lack of sleep, what we're being exposed to. All of these things are stress that EMF, we just don't get away from. So we are the gazelle, we are the zebra that we're never stopping from our running. We run and run and run and run. And so that stress response never goes away. And the implications that we're seeing are indicated in all of the disease that we're dealing with today. So this was just an introduction, and we still went down some rabbit holes. Now, when we get into each one of these, we're going to send out an email blast, some social media post, and we want you to submit your questions ahead of time, because we love to go down some rabbit holes. And we'll go down some rabbit holes with you on hormones and hormone metabolites. If you want to learn more about the work we do at Brio-Medical, go over to our website, brio-medical.com. You are going to see that amazing team that we have. And let me tell you what, I'm super proud of every one of them. And if any of you are listening out there, I love all of you, appreciate all of you, and let me tell you what the patients do as well. And our medical team as well. And just check out Practicing with Dr. Nathan Goodyear over at the drgoodyear.com website. And check us out on all social medias as well. We will be here every Thursday, 4:30 p.m. Pacific Standard Time right now, wherever you are in the world. Thank you for joining us, and we look forward to talking to you very soon on the next webinar next Thursday.